eye examination. Ophthalmoscope, and I think all midwives carry these now who are practicing at home. Yeah, and I'm not sure what training you've received for the use of them. I'm sure, again, I'm sorry if I'm teaching you how to suck eggs here. Right, eye examination. So a newborn baby, just been born, you're going to have a hell of a job seeing the eyes. Especially if it's a cephalic delivery, the eyes are all swollen, and in my experience that lasts for a few days. So the chances of seeing a red reflex in the first few days of life are quite low. And as soon as you start to pry the eyes open, the baby's going to cry. And what's the combined reflex with crying? Screwing up the eyes shut. So I think in order to get a decent red reflex, and it's not just the retina you're looking at, I'll talk about that shortly, you really need the baby a few more days of age than just been born. And I think in the newborn, about the only thing you're going to be able to tell is, are their eyes present and are they approximately the same size? And that, as an initial start, is quite a good thing. A little bit more esoteric, there is actually a pupil reaction at birth, and of course the red reflex is the thing you're looking for. So why are we looking for the red reflex? The most common eye abnormality is the subconjunctival hemorrhages, and that's from just being born. This is a common manifestation and completely benign. In fact, some of these babies, especially those born by obstructed labour, they can actually look quite Dracula-like, you know, with the whole whites of their eyes red. So that's, I'm sure you can reassure mothers by that. There's absolutely no morbidity associated with that. All right, so what are we looking at? These are cataracts. So you've got your ophthalmoscope, you've got a sort of slightly darkened room, and you've got your diopter's aperture, and you scroll down starting at the, you focus on the cornea and then focus back to the retina. So you go through the cornea, the vitreous humor, which is the fluid between the cornea and the back of the eye, which is probably beyond our scope to make comments on, and then have a look at the red reflex. All right, so the two lesions you're trying to pick up is cataracts, and look, it's pretty obvious that these babies have major cataracts, but most cataracts are going to be quite small and probably will not be seen by you with your initial examination, all right? But they're going to shine up as a light, a bright spot in your ophthalmological examination as you fold the diopters back, looking at the back of the eye, all right? These will be hard to pick up, small cataracts, and they'll manifest themselves over time. But hopefully a large cataract such as these, and of course this is rubella, will be obvious from the word go. Thankfully rare in this day and age. But it's the red reflex we're looking for, and that's meant to manifest there a red reflex. In fact, that's a white reflex, so that's retinoblastoma. But Pacific Island babies have a white red reflex. Have you noticed that? They have quite avascular retinas. The only way you can really, I suppose, diagnose that in Pacific Island babies is if there's asymmetry between one eye or the other. Although, of course, some forms of retinoblastoma are present in both eyes, rather than just unilaterally. What you're doing is just confirming a red reflex, but Pacific Island Maori babies, the red reflex may not be as red as you think. It certainly is in Caucasian babies. I'm not sure about Asian or Indian subcontinent babies. Also, as you're looking at the eye itself, just be aware of defects. That's a columboma. I know this is unusual, but that's a ding in the iris, but that columboma can manifest itself at any point right back to the retina. And there's a few syndromes that goes with that. So I think that sort of thing would be pretty obvious to you. And of course, infections in the first weeks of life. Thankfully, this is rare, although not absolutely rare. And of course, the infection manifestations that produces are profound. Chlamydia also produces an eye infection, probably not as florid as that, but can look quite unpleasant, eye bulging out, lots of discharge, and both those conditions need a combination of intravenous, and eye drop treatment. We have a lot of chlamydia positive mothers, but very little chlamydia eye infection, and maybe you as midwives or general practitioners see more of that than I do. They certainly don't come back to me, and we admit babies from the community after 2 weeks after birth. So we don't see very much chlamydia, and we see gonorrhea, but not the florid gonorrhea of this type here. But this is a common problem, which I think you'll find. Nasocromial sort of tear duct obstruction. And it has quite a high incidence in newborn babies. But by far the most efficacious treatment is just by the massaging technique, which I assume you've shown your mothers that? Yeah, okay. Look, it can get infected, but most of these, if you swab those, it'll be sterile, initially at least. So that's a quick run through of some of the eye manifestations. Squint. After 3 months of age, if you've got a baby with a squint, that needs to be referred. Now, I don't know if you can tell, but the way to diagnose a squint is to have your ophthalmoscope on the baby's eyes and look at them from a distance, and you should have the centre of the dot at the same point on both eyes. So if you've got especially can manifest itself in Asian races, you can have a pseudo squint where the mongoloid slant of the eye actually overlaps a little bit and looks like it's got a squint, but in fact the dot is in the middle of both eyes. So in fact there's not a squint there. But look, if you've got any doubts about squint after 3 months of age, if you think it's a permanent feature, that needs referral. Otherwise the optical parts of the brain that will lay down abnormal information as time goes by. It needs to be corrected. All right, a rash. That rash has created me a great deal of finance from private practice. That is, so what is that? What's that rash? Erythema toxicum. This is the most common referral that I have for newborn rashes. It's completely and utterly benign. And even when see the little papule there, I hope you can see it, that little papule there. So if you prick that and look at it under the microscope, it's filled with eosinophils. Nobody quite understands what the cause of that rash is. It's got various names, the heat rash, the hormone rash, various other names. It can be extremely florid, and it can actually, these papules can be so bunched up that it can become sort of three-dimensional, like little pyramids all over the skin, and can be completely and utterly distressing for the family concerned. So parents, look, I'm sure you know, parents get very concerned about that. It's completely benign, completely benign. But what you should also know is that rash can actually move on and form, that's another manifestation of it, of erythema toxicum. It can actually form quite a almost pustular papular formation. That's also, it's completely benign, but of course that might need a little more attention because that may be mimicking a true staphylococcal infection, although staph pustules tend to be more focused in the groin areas, the wet areas, and are larger in size and more fluid filled. So that might be just a manifestation of the erythema toxicum and may also be fine. Immunisations. Again, shroud waving. That's the tetanus case that had a high profile in Auckland. Was on a ventilator for many, many days. And again, I mean, remember, I see the worst side of things. Boy, whooping cough hasn't gone away. Whooping cough is one of the most infectious diseases known, imaginable, up there with measles. So look, the things that we immunise babies for are still in our community. So look, this is the 6-week immunisations. So I'm just trying to plug immunisations. What's the D stand for? A South African GP diagnosed diphtheria in North Auckland earlier this year. All right, so diphtheria is not gone, and he was the only one that knew it because he was used to seeing it in South Africa. So diphtheria has not gone away. Tetanus is dreadful. I mean, children are active. That rigor, the rigor, you have to see it to believe it. It is dreadful. And of course, the P, which is the one I highlighted before, what's that stand for? Pertussis, whooping cough. Whooping cough is the morbidity of whooping cough. And once the disease has gone away, the cough doesn't go away. It just keeps on going for ages and ages. So, like, I think I know this is controversial, but we might take our eye off the ball because the concept of herd immunity, that the rest of the community's immunised, so I don't need to immunise my child. Well, I think that eventually that kind of philosophy is going to backfire on the whole community. All right, so the polio is now an active vaccine. Haemophilus, I'll talk about Hep B because that's a big thing for me in South Auckland. Of course, rotavirus and the pneumococcal vaccines. And it's only the rotavirus that's in the 6th week. Oh, of course, there's BCG for some groups that's live and attenuated. Look, I just want to plug the hepatitis vaccine and immunoglobulin for those mothers that are hepatitis B positive. This combination of vaccination and immunoglobulin in the newborn period, it just has the most marvellous reduction in the complication of a dreadful condition. So if you're both surface antigen positive and the E surface antigen positive, perinatal transmission without our immunisation and vaccination, very, very high, very, very high. And if you're just surface antigen positive, also a modest perinatal transmission. And of course, in a huge majority of those people that get the perinatal transmission, chronic infection evolves. And by giving that combination of vaccine and immunoglobulin plus the subsequent vaccines, it reduces that perinatal transmission by 90%. There's not very many immunisations that work that effectively. And while this is not New Zealand data, the effect of chronic hepatitis from hepatitis B, of course, that's the thing that we fear the most, and it's kind of wiped it out. So look, even if quite often the mothers have come in with no antenatal care and you don't know what their hepatitis serology is, you can give the immunoglobulin up to 10 days and the hepatitis vaccine as close as possible to birth, but up to 12 hours to be effective. So I don't know what your labs are like, but hopefully you can get your surface antigen screen results back within that period of time. So just a plug for immunisations. Just look, a few take-home messages. Temperatures greater than 38 in babies less than 6 weeks. Vast majority are viral, but 15% of babies with a temperature greater than 38, it'll be a bacterial infection, therefore potentially a rapid progression. And UTIs are a relatively common cause of those fevers in the newborn period. They're more likely in boys or girls? Boys. First 6 weeks. Doesn't make sense, does it? Boys in the first 6 weeks more likely to have urinary tract infections than girls. Look, I know those are invasive, but in fact a clean catch urine is perfectly okay. How do you measure a temperature? Well, look, I mean, I know that the gold standard really is the rectal, and if you've got a temperature greater than 38 on rectal, it's a temperature, it's a real temperature. But of course, they're not exactly, they're not pragmatic, and rectal temperatures can be unacceptable to some parents. So electronic forms of taking temperatures are okay. Look, when compared with auxiliary, both will under-record the temperature, but again, as I said, tympanic is probably better than auxiliary temperatures. This is, of course, emergency care type stuff rather than neonatology. But we do acknowledge that the external auditory meatus in some babies are too small for a decent tympanic temperature to be measured. And look, just remember, any temperature greater than 39 with this technique here is only an approximation of what the true core temperature is. So look, and again, I have embraced my emergency care colleagues before every year that I've given this talk, I always just review it with them to make sure I'm not leading you down the garden path. In terms of treating fever, paracetamol is still their drug of choice. And that's the dose that they recommend for that age group there. The important thing is it doesn't actually abolish the fever, it just seems to make the baby more comfortable. And the standard dose as listed there will lower the core temperature by only about 1 degree, but that may be enough to make the baby more comfortable, avoid that class of medicine there for the reasons that I've listed. Now, you may be aware of the research that was linking early paracetamol treatment for fever with future allergic type degrees such as eczema, asthma and conjunctivitis. I am reassured, although I'm not myself up to the play with the literature, that work is fairly debunked, although the GPs in the audience might argue with me about that, based on some pretty good evidence. So paracetamol remains safe for babies, certainly less than the first 6 weeks of life, and also for the first year. Of course, if you can avoid giving any medicines, that would be for the better. Clinical signs of a baby becoming unwell in the first few days or weeks of life. That's said to be a normal respiratory rate in a newborn. I think the only time you can really take a normal respiratory rate is when a baby's asleep, and also be aware of periodic respirations. Babies have periods of apnea interspersed with periods of tachypnea. So we teach students to take that respiratory rate over at least 30 seconds and ideally a minute. Instability might be a clinical sign of impending unwellness. That's a normal, so-called normal heart rate for babies. Again, needs to be taken when asleep. Babies can have a surprisingly low heart rate when they're asleep, which is normal. While that says 160 there, I think up to sort of 180, maybe even a little higher, could be accepted as a normal heart rate in those babies. And while blood pressure is difficult to take in any infant, in terms of the newborn period, the mean arterial pressure should be approximately the same as the gestation. So I'm saying for term babies, it should be in the mid-40s to mid-40s mark, mean arterial pressure. And again, I'm probably teaching how to suck eggs, but listen to the experienced mother. Feeding is a great parameter of wellness or not. Yeah, just not right.